Good afternoon, everybody. Welcome to our Public Health PBRN monthly virtual meeting. We will be starting in just a few minutes.
So greetings everybody and welcome to the Public Health PBRN monthly virtual meeting for October. We'll get started in just a few minutes here. Greetings again everybody. This is the Public Health PBRN virtual meeting for October. Welcome everybody. We're going to give people just another minute or so to get dialed in and then we'll get started. Well, again, good body, and welcome to the October edition of the Public Health PBRN monthly virtual meeting. It looks like we have a good crowd assembled for our agenda this month, and as usual, we have an action-packed agenda, and also I think a very interesting agenda as well, particularly the first component of our agenda, our research in progress section. This month we're going to be hearing from some colleagues in the great state of Ohio and the RAFI network, our Ohio-based public health PBRN. The Ohio network has, like a lot of our networks, is very, very active, has a number of different applied public health research projects underway within their network, and a great group of colleagues across the state that work with that network, both in academic settings around the state as well as public health settings. And we're going to be hearing about some work in progress that's been one of the kind of ongoing themes, at least from a methodological perspective, in the themes that are of interest, have been of interest to the Ohio PBRN group, and that is interest in adapting this method of direct observation to studies of local public health practice. And so I know you all will be as interested as I am in hearing about their progress in using this method, adapting it for public health settings, and hearing about their experiences with the method, and also hearing about what they're starting to learn about the nature of public health practice and the nature of practice variation in public health through through the use of this method. So I think Dr. Scott Frank is going to be heading up our talk today. I think some colleagues of his as well. Dr. Frank, I think, is well known to our public health PBRN group. Is a real again ringleader in our network of PBRN people across the country. He is both a professor of public health and a professor of medicine at Case Western Reserve University, and plays roles in both the public health program as well as in other programs there in the university. And he's also a practicing local health official. He's the director of the Shaker Heights Health Department, a health department that's based there in the greater Cleveland area, as well as a practicing physician, a practicing family physician. So he wears many hats, and I'm never cease to be amazed at everything that Dr. Frank is able to manage, and the way in which he integrates insights across these different spheres in which he works. So with that, let me go ahead and turn it over to Dr. Frank and colleagues. Thanks for being with us today.
Hi, this is Scott Frank. Can everybody hear me?
Yep. Yes, you're coming across really loud and clear.
Great. Thank you, everybody. This is Scott. I really appreciate Glenn's very kind introduction, and look forward to sharing our information with you today. We are going to be presenting, as Glenn mentioned, on what we refer to as our DOLPH study, Direct Observation of Local Public Health, and that project focuses on the role of the local health department in prevention of foodborne outbreaks. What I'll be reporting on today is the first 140 cases or observed inspections that we were involved with. We will be presenting in a little more than a week at the APHA conference, and we'll be reporting there on 273 cases. But today we're going to share with you information that we presented at the Association of Ohio Health Commissioners in September, and that was a preliminary analysis representing 140 cases. I may make some comments on how things have changed or stayed the same as we've done the later analysis, but the numbers you see will be that first 140. Trying to get these slides to move. We have arrows here, but it doesn't seem to be wanting to move.
I'm sorry about that. Let's see. How's that?
Okay, great. I got it. Thank you. So let me move forward with the slides.
You should be able to move them now. There you go.
Okay, there we go. Now more than one at a time. So I am going to spend a minute just talking about the purpose of the study. Ostensibly, it is to characterize public health practice, structure, process, and outcome of the local health department role in foodborne illness prevention, investigation, and management. But a secondary purpose of this study, as Glenn mentioned, is to examine the accuracy, practicality, and differential utility of a direct observation approach to understanding the complexity of public health practice while reducing research error variation. I'm also going to comment a bit on choosing foodborne outbreaks as a public health archetype to test this this research model. The decision to focus on foodborne outbreaks really occurred at one of our Association of Ohio Health Commissioners meeting, where we got together with a large group of health commissioners and talked about how this approach might be applied to something that was important in public health. Foodborne outbreak represents, for many people, the face of public health. They know public health as the people who do the restaurant inspections, and to some, in fact, that's all that we are. But in addition to that, foodborne outbreak is listed as under the enforcement component of our 10 essential public health services. Food safety is among the CDC's 6 winnable battles. So foodborne outbreak is important. In 2011, the CDC estimated that foodborne illness affected about 1 in 6 Americans, 48 million people, with 128,000 hospitalized and 3,000 deaths. In addition, the economic burden from foodborne illness is substantial, average of about $1,600 per case, and roughly $77 billion cost of foodborne illness annually. In Ohio, in 2010, there were 67 foodborne outbreaks affecting 911 people in 28 of Ohio's 88 counties. There was 1 multi-state infection involved as well, and about 90% of the foodborne outbreaks counted restaurants as the source of the foodborne outbreaks. In addition, the area of environmental health in local health departments is under-investigated, and many of the sanitarians might believe underappreciated. So part of what we're doing is examining myth versus reality in this project. Some of the myths, what we believe to be myths, but we need to investigate in order to know, is that sanitarians are nothing more than the mayonnaise police, that they simply enforce or police restaurants rather than having a broader range of impact on food safety, that food service establishments hate inspections would be another common belief that we will be investigating, that the relationships between sanitarians and what you'll be hearing me refer to as PIC. PIC stands for the person in charge at the food service establishment, and that those relationships are contentious, and that little is accomplished during these food service inspections. So we're examining those to see whether they're valid or whether in fact they are myths as part of what we'll be doing with this study. Let me also comment that I'm happy to have people chime in and interrupt during the presentation if you have questions or comments that you want to make. I'll be trying to go through the rest of the slides pretty quickly in order to leave some time for discussion as well. So this represents the 7 academic sites that are involved in the project. We do have 7 academic sites. Each site relates to 3 to 5 local health departments. Each site has 3 to 5 student observers who are involved in the direct observation of the sanitarian inspections. Well, it seems that it should be as simple as clicking on that arrow. Sometimes it works and sometimes it doesn't.
Sorry about that, Scott. If you just want to tell me when to advance the slide, if it's not working for you, just let me know.
I'm going to actually let Michelle do it because she seems to be doing better with it than I am.
Okay.
So we'll go ahead. Got that. There is also here a list of our co-investigators. I'm not going to go through that in any detail except to let you see that it's there. A list of our 21 participating health departments, and you can also just take a look at that. What I would say is that those sites are geographically diverse across the state, making the approach more generalizable. The sample of health departments is a convenient sample. It's the health departments that tend to be closest to or have relationships with these academic settings. But fortunately, a number of those, it is a diverse set of health departments, both in size and location. In other words, we have both rural, urban, suburban, city, county health departments all represented. So our approach is a mixed method approach. Includes qualitative and quantitative components, including both interview and observational data. There will be also data integration with secondary data that's available to us, particularly what we in Ohio refer to as our AFR, or Annual Financial Report. And we'll be looking at the relationship between public health spending in these jurisdictions and findings that we have. Also looking at the sociodemographics of the census tracts in which the food service establishments are located, to see how the outcomes and process differ based on the demographic characteristics of the census tract that it's located in. Finally, we also do have access to local health department performance standards data that we'll also be integrating into parts of our analysis. This little figure represents our attempt to describe exactly what we're doing, and we like it. It shows the epidemiologic triangle with host, agent, and environment as what we're examining, that we're doing that through the use of existing data, observation, and interviews. We're investigating prevention, investigation, and management. And for these, we're addressing process, structure, and outcome. But you'll also notice right in the center, and the area that is perhaps uniquely well addressed by direct observation, is an attempt to investigate the complexity of what happens in local health departments and in the context of these inspections and management of the foodborne illnesses. So this is our graphic of what exactly we're trying to accomplish with this project. I'm going to just go through this very quickly. This is how we explain to the local health departments and others what we're trying to do. We're trying to illuminate the black box of local public health. We know what goes into it: policy, funding, partnerships, human capital, population needs. We know that that black box represents local health departments and delivery systems. We know that there are both valid and error sources of variation between these different health departments. We know that service delivery comes out, and that these things impact health, economics, and systems outcomes. But our attempt is to get a better look at the what's inside the black box. So as we illuminate the black box, we'll be looking at public health systems, agencies, population and environment, decision supports, outputs and outcomes, all of these leading to strategic decisions, which actually then lead to the outputs and outcomes. This is what we're attempting to do. Some of the tools include profiles of the local health departments and jurisdictions, of the sanitarians, and then our direct observation protocol, which actually includes a pre-inspection interview with the sanitarian, then observation during the inspection, during which the student observer does not speak or ask questions to the sanitarian at all, simply observes. And then at the end of the session, there is a post-inspection interview, at which time the student observer can discuss details from the inspection with the sanitarian, and also administers a structured interview that gathers information for us. The observational protocol also is heavy with field notes in addition to the quantitative observations that are made in this qualitative setting, and that's what we're using for our tools. We'll also be in this setting reporting on, as I mentioned, 140 direct observations. At the time of this data, we had 29 sanitarians in the database. We now have 52 in the database and 72 who've been consented and will be participating moving forward. At the time of this investigation, we only had 3 of our sites having reported data. We now have 5 out of our 7 sites having reported data, with an additional site having data but not getting it to us yet, and 1 site that has not gotten up and moving yet. So this next slide represents our early attempts to investigate the inter-rater reliability as it related to the observational protocol, and you can see that to a large extent there is a strong degree of correspondence between the gold standard in this case and the student observer responses. One more look at the same thing. We'll be going through the different sorts of issues that have been addressed in the observational protocol as we go through our results here. But these early results give us a high degree of confidence that, in fact, we're able to have diverse student observers in diverse settings and still have shared observations that are accurate. So the sanitarians who are involved in the data we'll be reviewing today are 38 years old on average, just slightly more than half male, a small portion African American, average 8 years in their current position, 11 years as a sanitarian. About 2/3 of those who we're reporting on are generalists, that is, that they are involved both with food service inspection and other environmental health duties, whereas about 1/3 do food service inspections exclusively in their job. This is the time allocation for those who participated, with about 61% of the time being spent on food inspections, 21% with paperwork, 10% nuisance, and you can see the other data there. It's an experienced group. 83% have experienced suspected foodborne outbreaks. 70% have experienced verified foodborne outbreaks. About 45% consider their job very demanding, and about nearly 65% perceive limitations in their ability to complete food inspections because of competing demands. Those would be the generalist sanitarians who would have that perception, I presume. Again, you can see some of the issues that we asked the sanitarians. About a quarter state that they like investigating foodborne outbreaks. Nearly 60% don't mind the paperwork. 0% like the paperwork. Nearly 60% like conducting the food inspections. Nearly 70% like interacting with the PICs, and 0% say they dislike those interactions. Nearly, or a little more than 2/3 report that they like doing food safety education during the inspections, and about 70% say that they like being involved in continuing education, which I think speaks well of our sanitarian group. This slide is a little bit complex, so I'm going to give you a brief summary of the findings. In this slide, I thought I brought that summary with me, but it doesn't appear that I have. This essentially looks at the PIC's attitudes about the sanitarians' attitudes about PICs, the extent to which they believe the statement that PICs will do anything to save money, that they're cooperative, that PICs dislike inspections, whether there's a cordial relationship, the extent to which PICs have a good understanding of food safety, and the extent to which the sanitarians believe their inspections directly prevent foodborne outbreaks, the percent of the inspections they do that prevent foodborne outbreaks. And the bottom line is that a majority of sanitarians have positive attitudes about PICs. About 60% don't believe that a smaller portion of PICs will do anything to save money. All of the sanitarians say that more than 60% of PICs are cooperative. Again, a strong preponderance say that it's a minority of PICs who dislike inspections. Vast majority report cordial relationships with the PICs. Most believe that PICs have a good understanding of food safety. And about 30% believe that more than 60% of their investigations result directly in prevention of foodborne outbreaks. And during the pre-inspection interview, sanitarians stated that they had previously inspected this food service establishment. 2/3 related a positive history with those previous inspections. About 7% related that the place they were going into is what we refer to as a heart sink inspection. We've borrowed this phrase from medicine, where heart sink patients represent visits where before you even go into the room, your heart sinks a bit, knowing that it will be a difficult encounter. So this is the application of that to our inspections. By far, 90% are more complex food service establishment risk categories, categories 3 or 4. And at the start of the inspection, nearly 60% addressed the PIC by name or title. Only about 2/3 of the time did they actually introduce themselves to the PIC. When they did, it tended to be by their first name. You can see they tended to be cordial, wash hands. They tended to interact with more than just the PIC. On average, 3 employees per inspection were also involved in direct verbal interactions with the inspector. Nearly 90% spent 1 to 5 minutes talking with the sanitarian prior to the start of the inspection. And about 10% of the time, PICs appeared to be stalling the sanitarian at the start of the inspection to delay the onset of the inspection. This actually was an item that was added at the suggestion of the sanitarians after we did our early piloting. Briefly, some of the characteristics of the PICs is that 51% of them were female. About 65% fell into the 30 to 50-year age group. About 56% of the time it was the manager, 17% of the time owner, and other for the remainder. By far, most of the PICs involved had good facility with the English language, with 95% speaking good or excellent English, and comprehension at 98%, but in a meaningful minority of 5% speaking fair or worse, or comprehending 2% comprehending fair or worse. Some of the interactions between the sanitarians and the PIC from the PIC behavior. Sorry, would you do PIC behavior first? Next slide. Okay. The PICs were not hesitant to admit when they didn't know something. Nearly 50% admitted uncertainty during the inspection. Widely used humor to cope during the inspections. Tended to interrupt the PIC fairly rarely. Only about 1 out of 5 interrupted. A very small number reported conflicts or argumentation. The feedback to the PIC generally occurred in private. Though occurring in private, it was interrupted nearly 10% of the time. About 14% of the PICs offered favors to the sanitarians. From the sanitarian side, they were much less likely to admit uncertainty. Also broadly used humor, tended to interrupt the PIC more often than the PIC interrupted them. I'm pleased to say, this is nothing like my own field, that only about 4% of the time was unexplained jargon used. The feedback given to the PICs tended to be framed in a positive fashion, though there is a significant minority that framed the feedback negatively. Only a small number were threatened with punitive action, and though 14% offered favors, no favors were accepted by the sanitarians. This is a brief description of some of the tools utilized, and I will say that as we've gotten the larger group in, these numbers have changed a bit with a higher level of use of a number of the different tools. These are areas that were inspected, and I think the thing that I'd like you to pay attention to here is really very much thoroughness of the inspections that are reported with in the range of 85% or higher. I think on our data, when we have our 270, they're all in the range of 85% or higher, with each of these different areas being attended to. These are actions taken by the sanitarians. You can see that there's a physical component, squatting or bending, looking under or behind things, checking temperatures, giving advice are all listed here among the sanitarian actions. We had an interesting question when we presented at AOHC about the squatting and bending and why we included that in the study. We're seeking to fully describe what's being done, number one. Number two, we want to get a sense of thoroughness. But this health commissioner was especially glad that we included this, because if she knows that 4.2 squats or bends occur during an average inspection, she has a sanitarian who cannot squat or bend, who she's been trying to shift into a different role, and saw this as supportive information for that kind of action. Again, the next slide describes areas that are examined. This actually will have even a higher level of consistency when we do a little bit of division of the type of establishment that is involved, because not all of the establishments, we examined grocery stores, corner stores, gas stations, all of which have food and require inspection. So, for example, there isn't a dishwasher in a gas station. So as we divide out those different areas, we'll see even a higher level of thoroughness. In terms of the checkout, citations were given in about 67% of inspections, average of 2.2 citations per inspection. Verbal corrections were given in about 89% of inspections, with an average of about 1.9 verbal corrections per inspection. I think that somebody has their phone unmuted. We're hearing it here. You may want to check your mute. If you mean to be speaking up, we're happy to have you, but otherwise, please go ahead and mute. So the violations were dealt with during the inspection more than half the time. There was a follow-up scheduled to check in on the violation in about a quarter, and no follow-up was scheduled at the end of the inspection for about a quarter of the violations. Checkout also pointed out that it was only on very rare occasions that the PIC or RS raised their voice in anger. They are thought to be cooperative nearly all the time. The PIC was thought to be engaged. That actually is a reverse number, 87% of the time. At the end of the visit, the PIC thanked the sanitarian thanked the PIC about 90% of the time. Only on rare occasions was the PIC noted to question the sanitarian's knowledge, judgment, fairness, or authority. And about a little bit more than 10% of the time, when the sanitarian thought they were done and were preparing to leave, there were further questions that were brought up by the PIC. This is the duration of the checkout. Most took 1 to 5 minutes. Sorry, the largest category is 1 to 5 minutes, but most took more than 5 minutes. And this represents the post-inspection interview, parts of that. You can see that on average, the inspections were deemed as easy or very easy. We asked separately about the interpersonal interactions during the inspections, and again, those were deemed in most cases to be easy or very easy. We're frankly more interested in the ones that were difficult or very difficult, and we'll be looking in more detail at that group as well. This describes how satisfied the sanitarian was with the way the inspection went, and you can see again the preponderance are satisfied or very satisfied, and how concerned they are about problems with that food service establishment in the future. You can see that a bit more than a quarter have at least some concern about future problems at that establishment. About 7% of the sanitarians felt that during that inspection, there was some influence of the student observer on their actions. They were asked to say whether it was a little bit of influence or a lot, and all of these responses were a little, it may have affected their actions to a small degree. Limitations of this study include that potential observer bias, that these are preliminary findings, and that we've simply just shared descriptive findings with you with no tests of association done for this presentation. Some of the strengths of our study include our strong inter-rater reliability, that we're using an approach that has not been used extensively, at least in public health, not used to the extent that we can find it. We have detailed data available. We have broad geographic spread, particularly moving forward. That spread will be even more wide-reaching in Ohio. We have the ability to combine the original data that we're collecting with existing data, and we believe that with the good inter-rater reliability, it decreases research error variation when compared, for example, to asking self-report about the same kinds of issues. I will just comment on some of the lessons learned so far. I mentioned our strong inter-rater reliability. And the first lesson learned is that we believe the methodology works, demonstrated by the inter-rater reliability, by rich, intriguing findings. We believe that it does indeed examine the complexity of what goes on in the public health setting. We are pleased that the student observers offer enthusiastic endorsement of their involvement in the project, and that the sanitarians also express an enthusiasm and comment that they do not feel that it interferes with their ability to accomplish their job. Among the things that are difficult, have been difficult with the project, include just the general comment that multi-site studies are difficult. We have the 7 different sites, and we've had some issues getting everybody up and running. So studies are difficult but rewarding. And they're especially difficult when we're doing them on a relatively small budget, giving us less leverage to push those programs forward. The IRB process across sites took much longer than we believe necessary, and has represented a frustration for us at the central site and for many of our other sites. The methodology is complex to implement, which essentially has taught us that each site needs a coordinator who is dedicated to this process and has that as a priority to make sure that it's getting done. But I would also say, despite the difficulties of the multi-site approach, this project could not have been done, or at least not have been done nearly as well if we had tried to accomplish it from just one site. So those are my comments, and I think I'm maybe just a little over how much time I planned, but that's what we would share as our preliminary findings from our project.
Fantastic. Thank you so much, Scott. Very, very interesting work, and I think in many ways pretty groundbreaking, at least, or certainly from a methodological perspective, in terms of using this methodology. Do we have some questions for Dr. Frank and his colleagues in the RAFI network about their work in this area so far?
Yes, Glenn, we have a question from Dr. Shah. Dr. Shah, you can ask your question now.
Hi. This is Gulzar Shah with the Georgia PBRN, and thank you very much for a really good presentation. I was especially intrigued by a very innovative use of the direct observation, and one of the questions I have is, the possible Hawthorne effect. So I was wondering if you have noticed or you suspected any Hawthorne effect, or the effect that emerges when people know that they are being observed. So for instance, I saw that none of the sanitarians accepted any gifts, for example. And would that have been because they knew that they are being observed? And so what are the implications of this bias on this method in this kind of use?
My response would be that we need to accept that as a limitation of the method. We don't, or we have not come up with a way to investigate the true difference between an observed session and an unobserved session. We have received one suggestion that we considered doing at the beginning of the study and dismissed it because we felt it would unduly increase our difficulty with the IRB, but that would be to interview the PICs following the session to ask their perception of whether that session represented any difference from the usual inspection that they had received. That may be something that could be done at some point in the future, but we have not integrated it at this point. I don't think that would even necessarily be viewed as a gold standard since their own recall bias would be a complicating factor there. It is an important question for the methodology. I can tell you that in other settings where direct observation has been used, these issues have also been addressed, and I think that what we can say is that this represents best behavior, and we need to accept it as best behavior, but that if best behavior doesn't even reach the standards that we're looking for, that would really represent a problem.
Thank you.
And Anna Hoover from the Coordinating Center has got a question. Anna, why don't you go ahead?
Okay, I apologize for the background noise. I'm dialing in remotely. I'm a communications researcher, and I'm very interested in your findings about the amount of humor used in these interactions, Scott. I believe 68% and 60%. I was wondering, and I know this wasn't the purpose of the study, but if you noticed any variation in how those interactions went, comfort levels or the positive or negativity of the positiveness or negativity of the interaction. And I was just thinking it could be an interesting follow-on study to inform best practices. So I'd be interested in hearing your thoughts on the use of humor in those cases.
Well, you've hit the nail on the head for what we intend to do with this data moving forward, Anna. The questions regarding the RS-PIC interactions were really taken from previous research that we did looking at doctor-patient interactions. And one of the down and dirty markers that we used for patient satisfaction in that observational study involved whether the patient thanked the doctor at the end of the visit. It turned out to be a remarkably robust measure of a proxy for patient satisfaction, perhaps even better than asking the patients. Anybody who's done health services research understands that there's a very strong bias towards satisfaction with the physician, but we really found that as a useful proxy for satisfaction. And in that study, we found strong relationships between positive physician behaviors like the use of humor, the use of non-clinical touch, admitting uncertainty, all as things that were related to this thank you at the end of the visit, this proxy for patient satisfaction. So we'll be looking at patterns of behavior as they relate to outcomes, one of those being the thank you at the end of the visit, but others being how the checkout went with the between the PIC and the RS at the end of the visit. We'll be looking particularly, as I mentioned, at those outliers that had difficult encounters to see how those differed from those that were more routine in their nature. So that will be an important thing we're looking at, and I think really represents what we're talking about when we're saying looking at the complexity of these encounters, not just what they do, but what is the relationship, how does that relationship affect the manner in which the inspection proceeds. So that's very much part of what we're hoping to discern.
Excellent. And I saw a hand from Paul Irwin. Paul, do you have a question you want to ask?
Thanks, Glenn. I think Dr. Frank answered it with his response to Anna, and it mainly has to do with things that are being learned that could only have been learned through observation that could lead to improved public health practice.
Yeah, I do think that some of the interaction stuff does get at that, but I think that in many ways we see this study as affirmational. We believe that it will. If it doesn't, we'll say it, but we believe that it will affirm the importance and role of the sanitarian in protecting our communities from foodborne illness. And I think that a number of the questions that can be answered through data integration, I think also will be especially telling. So for example, our restaurants that are inspected in census tracts that have high poverty rates, are the interactions between the RS and the PIC any different in those communities than other communities? Are there more violations? Do the sanitarians conduct themselves in a different manner? So a lot of different things that we believe, because we have the detailed level of data on our original data collection, that when we begin to share that with, measure it across the different sociodemographic and public health spending variables we have, that will make it that much more interesting and get that much more at that complexity issue. Size of jurisdictions, that generalist versus specialist sanitarian, do specialist sanitarians function more effectively than generalist sanitarians? Those are all things that I think would be answered in a superior fashion with this approach to others that might be tried.
Thank you.
Excellent. I know we're running short on time, but I see Golzar's got one more quick question from our Georgia network. Golzar, you want to go ahead quickly?
Yes, and so my quick question is, Dr. Frank, that any of the participating study sites, do they have consumer complaint surveillance system, like an automated surveillance system? And do you happen to know if any of those inspections were triggered because of a complaint?
Yes, we do keep track of the source of the inspection, and in our case, to date, we have very few of the inspections that were triggered by a complaint. About 88% of them, of the inspections, are routine and unscheduled inspections. About 4% represent either a follow-up or complaint, and about 4%, and this is actually all on the 273 that I've now examined, and about 4% represent inspections of new or newly opening or pre-licensing inspections that are required prior to the opening of a new establishment.
Great, thank you very much. That answers my question.
Fantastic, and thank you so much, Scott, for taking time to do this. Obviously, very, very interesting work, and we all want to stay tuned to how this progresses. A classic study, I think, looking at a very detailed view of practice variation in public health. And as you mentioned, next steps, you're going to begin to integrate these data with other data sources to explore some of the drivers of that variation and possibly also some of the consequences of that variation over time. So we'll look forward to continuing to learn from this great project. Thank you so much. And so now we should switch gears a bit. We'll turn to the next components of our agenda, the more administrative components of our monthly agenda today. Starting with a few updates on the research front. We wanted to give you some updates on some important developments in other ongoing research in the PBRN program. First of all, just to check in on our multi-network IMPROVE study. Again, I think everyone on the call is familiar with our IMPROVE study, where we have 6 participating PBRNs with us in that study that will be studying a core set of measures, collecting data on a core set of measures of public health service delivery across the settings represented in those networks. That study has made some great progress earlier this month. We had representatives from each of the 5 the 6 participating networks convened for a rapid meeting out in Denver early this month to help us hone a large set of possible candidate measures into a short set of short list measures that will be used for this study. We made great progress. We've succeeded in identifying that short list, and then we had each of our representatives take that short list of measures back to their colleagues in the 6 networks. We're doing a little more vetting and refining on that short list of measures this month, and hope to be ready to go early next month with our final set of measures and move into data collection, the data collection phase of that study. So we're real excited by the progress we were able to make this month with our Delphi assessment of those candidate measures and the really difficult but very good work that we did earlier this month to hone that list down. So thanks again to our improved networks, and we'll look forward to continuing to work with you on that study as it moves forward. We also note that we've reached October is the 1-year mark for our RACE studies, the Research Acceleration and Capacity Enhancement studies that started 1 year ago this month. A set of eight of our public health PBRNs have these RACE awards. Some focusing in on building in a disparities disparities component to ongoing PBRN research. Some other projects involve adding some new methodological approaches to ongoing PBRN research projects. So, and we know that some of those projects are beginning to bear fruit and starting to have preliminary findings come out. Most of those, I think all of those studies have another 6 months or so left on them, but we do want to remind our networks who have those RACE studies to make sure you submit your 1-year progress reports, your 1-year financial and narrative reports on the progress of your studies to date, and then of course let us know at the coordinating center if we can be helpful. Again, as you start to have findings come out of your studies, we certainly are especially keen on working with you and helping to disseminate those findings, as well as any needs that might come up from a technical assistance standpoint. But it's great to see us get to that phase with the RACE awards. We also note that we have a new round of quick strike studies that have been selected for funding, and that will be starting up over the next couple of weeks. 3 additional quick strike studies were selected from our 2012 round of applications, and so we're going to look forward to those studies getting up and running and being completed over the next 6 months. 2 of those studies are actually based in the Ohio Public Health PBRN and the Ohio network, looking at a couple of different issues. One study in Ohio is looking at health department consolidations that are occurring across that state, and particularly looking at the financial consequences of those consolidations, using some unique data sources that are available there in the state of Ohio. So we're interested in obviously in tracking the progress of that study, because these consolidations and other strategies for sharing and pooling resources are becoming increasingly common across the country, and so that study will offer a fairly detailed lens of the financial and economic consequences of consolidation. A second quick strike study that was selected also for implementation through the Ohio network with a somewhat different cast of characters involves looking at basically a focus study to estimate the cost of delivering a core set of local public health services. This quick strike study has been triggered in part by a statewide effort in the Ohio public health system to identify a minimum package of public health services and to implement policies and strategies to assure the delivery of that minimum package across Ohio's local public health agencies and its partners. And so this study is designed, is well timed, to actually look at the costs required to deliver that minimum package of services. And again, this issue is also certainly very important to Ohio, but has a lot of national implications as well, as from both a practice and a policy perspective. Our public health system looks to understand with more depth what it takes from a financial and a human resources perspective to deliver core services. So we're also excited about that quick strike study as well. That study is going to be testing some some novel methods for measuring cost and documenting cost of delivery that we think lots of others who are working with us in this field can learn from. So that's the second quick strike that was funded. The third quick strike study funded in this round is actually will be conducted by the Georgia Public Health PBRN, looking at another hot topic in the field, and that is the use of health information exchange systems and technologies, and the ways in which public health agencies are interfacing with the clinical care system around health information exchange, looking at how that's playing out in a state that is pretty far along the road toward implementing its health information exchange capacities, and thinking about how the public health system roles in that set of activities. So the Georgia PBRN will be conducting a study looking at those issues using a combination of data sources, looking at those issues from both the public health agency side as well as the primary care physician side of that exchange. And so we're excited about that study as well. So 3 new quick strike studies starting up this month. We also note another set of new studies that were announced this month. The set of studies that have been funded through the Robert Johnson Foundation's call for natural experiment studies in public health services and systems. A set of 8 new studies were funded under that, were announced this month under that initiative. And several of those studies actually involve some of our public health PBRNs around the country who were involved in the conduct of those studies. We'll make sure we'll profile all these new studies in the next edition of our public health PBRN newsletter. So if you want more details about these studies and their approaches, look for updates in the next edition of the public health PBRN news. Switching gears to our next agenda item, we did want to highlight a couple of new funding opportunities that are on the horizon now that may be of particular interest to our public health PBRNs. One is an opportunity that we've talked about on a number of other occasions, but I just want to make sure people are aware of, and that is the second round of funding opportunities that are being provided through the Patient-Centered Outcomes Research Institute, the CORI, have been announced, and those are all available now. I think they have the second round has submission deadlines that fall in December of this year, so a relatively short turnaround time. But again, as we talked before, the CORI's research agenda definitely has considerable synergy with the kind of work that we're doing in PHSSR and that our public health PBRNs are doing. So we encourage our public health PBRNs to take a look at those funding opportunities. They're posted on the PCORI website, pcori.org. Even though the PCORI is a quasi-federal agency, but technically a not-for-profit organization that funds patient-centered outcomes research and comparative effectiveness research, both clinically oriented as well as prevention and community-oriented research. And so we encourage you to take a look at those opportunities. We've reached out to a couple of you networks who we know have interests that are particularly well situated from a comparative effectiveness or patient-centered outcomes frame. And so, but again, we're at the Coordinating Center eager to help others of you who might be interested in these opportunities or might be interested in thinking through how your research interests might fit within the lens of the CORI research. Don't hesitate to let us know. Send us an email or give us a call. We're glad to chat with you on that. We also note our colleagues at the Public Health Law Research Program continue to do great work and to sponsor great work looking at the impact of law and policy on public health. And again, we know that a number of our PBRNs have research going that's in this area. Several of our PBRNs have already been funded through prior research awards from the PHLR program. We note that right now our colleagues there are have a new initiative around strategic and targeted research and basically have a call out for ideas. If you have an idea for a research area, a research program that is that would benefit from a strategic focus and a targeted focus, you can submit that idea now to the PHLR program for consideration. So there is an open call for ideas right now. A little different from a call for proposals, but if you've got a great idea, we definitely encourage you to submit that to our colleagues there for further consideration. And again, more information is available on their website, publichealthlawresearch.org, and the colleagues at the coordinating center there at Temple University who coordinate that. And then finally, briefly, we will soon be launching the next round of mini grants in public health services and systems research through the National Coordinating Center for PHSSR that's also based here at the University of Kentucky. And so we want to alert you to that. Announcements on this will be forthcoming. I think the plan is to formally roll out that call for applications at the APHA meeting next week. So stay tuned for that. Those details will obviously be posted on our PHSSR Coordinating Center website, publichealthsystems.org. And again, we know that that's been an important mechanism for a number of our colleagues in the public health PBRNs who have had doctoral students or recently completed postdocs, newly minted research faculty who are working with some of our PBRNs have benefited from that mini grant program. So definitely keep that on your horizon. Any questions on those agenda items? Feel free to raise your hand. We're using a somewhat new webinar technology here, and so the hand raising seems to work quite well. Feel free to raise your hand if you've got a question, or if you can't do that, if you're just on the phone, just jump right in with a voice, and we'll give you the stage. Well, hearing none, we'll go ahead and move on through our agenda. Next up, some updates from a program monitoring perspective. First, just to reiterate, we have been moving through our quarterly progress interviews with the leaders within all of our public health PBRNs. Thank you so much for those of you who have already spent time with us and our staff on the phone, just letting us check in with the progress of your various research projects, letting us check in with any changes that are occurring in your network composition, your members, and key players. That's very, very helpful to us, and we thank you for carving out that time. If we haven't got to you yet, you're on our schedule, and our staff are working with you to set up a time to do that. We find it very, very helpful. Helps us update our records and our website, things like that. Also helps us be much more proactive in helping you disseminate the great work that you're doing, particularly as we get early warning on findings, early warning on papers and presentations and other products that you're producing. So again, thank you so much for that. On a related note, we also wanted to remind folks, as we talked about here, in the last couple of months, that there is an evaluation underway of the Robert Johnson Foundation's public health services and systems research portfolio writ large that our colleagues at the Urban Institute are conducting. And a significant component of that involves our public health PBRN program. And so our colleagues at the Urban Institute have their evaluation process in place. Part of that involves a survey that they have sent out, an electronic survey, and they've asked key players in all of our public health PBRNs our affiliates, as well as our primary networks to respond to that survey. And I was just talking with Randy Boberg yesterday, in fact, about that progress. They are getting a very good response rate to their survey. They again wanted me to relay their thanks to the majority of you in our PBRN community who have responded to that survey. Thank you so much for doing that. And also a reminder for those of you who haven't yet responded to that survey to please take the time to do that. Very, very important feedback that this evaluation is providing to us and to the foundation about how things are working with the PHSR portfolio and the PBRN's component of that portfolio. So very, very important for you to take the time to fill out that survey. You know, they're targeting a couple of different people in each of our networks, a couple of both leaders as well as participants. So so again, it would be helpful for those of you who are leaders in your network if you could send out that reminder as well to your larger network that if they get a request to fill out a survey from the Urban Institute on behalf of the foundation on this PHSR evaluation, that please carve out some time to work through that. It's not an onerous survey. I've been through it myself, and it's going to provide us with some very useful information. Also on that note, I know we've got to move on. I'm being long-winded here, but a second component of the Urban Institute evaluation will involve some site visits to a select very fortunate group of public health PBRNs to allow the Urban to get a more on-the-ground sense of how public health PBRNs operate. And so a small number of you will be selected for a site visit. We're helping the Urban Institute make some informed decisions about their sampling and site selection strategy for that. One of the information sources that the Urban Institute wants to use to help make that selection is the bibliographies that you all develop and submit on an annual basis about the products basically that your network produces over the year, papers, presentations, etc. And so this is just a reminder. It's always good practice to keep that bibliography up to date, particularly now as you all are doing having lots of dissemination products and lots of dissemination activities. Please keep those bibliographies up to date. Make sure that you're capturing those papers, those policy briefs, those presentations that are occurring at state and national meetings. That's the record of your progress. You're obviously going to want to report that bibliography to the foundation on an annual basis and submit those products as you complete them, as we'll talk about later today, submitting those to the foundation and to us. But it's good to keep track of that in the bibliography. And in particular, we're going to be using those bibliographies to help Urban make some informed decisions about site selection for the site visit component. Okay. Enough about the evaluation work. Let me pause and see if there's any questions briefly on that before we move on to some of our other items here. Hearing none, it's a nice segue from evaluation into some updates on dissemination activities and opportunities. Again, we're at a phase in these PBRN life cycles where there is a lot happening. You all are producing a lot of good work and working hard to get this information out to decision makers in practice and policy and research who can use it. And so a couple of highlights here. Obviously next week we've got the APHA annual meeting kicking off. We've got a large collection of PBRN related research being presented at APHA. We've compiled a list of all of your presentations that you've told us about, that we know about at this stage. We'll be emailing out in another day or two that list to our folks on our PBRN email list. Again, because we know that a number of you in the networks will want to get to presentations that are happening by other PBRNs. So we'll be getting that out to you shortly, well in advance of you landing on site in San Francisco, so that you can perhaps use that list to plan your time wisely at APHA. We'll also have that list blown up on a poster that'll be at our booth at the APHA exhibit hall, and we'll have a handout available as well. So if you again, if you have colleagues who are in particular interested in hitting these PBRN sessions at APHA, we'll have that available at the booth as well if you don't have your email handy or can't remember when that compelling PBRN presentation might be happening. We'll be doing that. We are also Anna and Elizabeth on our staff are going to be organizing an informal gathering of PBRN colleagues at APHA for those who might be interested in getting together informally with some of your colleagues in the other PBRN. We're going to have an informal gathering, most likely on Sunday night. That looks like probably the best night where there's not a lot of other competing things. Something early evening, before dinner, where just a location where we can convene, for some drinks and conversation before folks head off to dinner or to other things on their agenda. So we'll also be including that in the email that will go out with our APHA schedule. And so we hope to see as many of you who can make it to that as well. It's always we never get enough time in person to talk and network and share information. So for those of you who are interested and who will be at APHA, we'll be sending that out. The time and location on that here very shortly. A couple of other of our dissemination activities, and I know I need to step it up here. We do have the Frontier special issue featuring PBRN research that is scheduled to be released later this month. So again, thank you for those of you who have articles in that special issue. That will be released as our October issue, and we're very excited about that. We also have the Journal of Public Health Management and Practice special issue on PBRN and PHSSR research. That is now available, at least in electronic form and shortly in hard copy form, now available as the November-December issue of that journal. It is what we believe to be the largest single issue in terms of just sheer number of pages in the journal's history. That's a testament to the great volume of good research that's happening in this field. And again, it might count about 2/3 of those papers, of those 18 papers, are actually research projects that were implemented through or in coordination with Public Health PBRN. So you all have been a major engine behind that work. Congratulations to those of you who are authors on papers of that issue. That issue will be officially unveiled at the APHA meeting, and the publisher. And so if you'll please stop by the Journal of Public Health Management and Practice booth to pick up a copy. They're also going to be announcing a new iPad, iPhone app that allows free access to this issue. And so you can stop by the booth for more information about that. Very, very exciting progress in dissemination of PBRN research there. We also have the American Journal of Preventive Medicine PBRN theme issue that is moving forward and will be moving into production shortly, scheduled for release in early 2013. We've got 5 PBRN papers in that theme issue as well, so stay tuned for more progress on that. We'll be keeping you up to date as we get more information about publication date on that. And then finally, we want to also highlight that the inaugural release of our React podcast hit cyberspace earlier this month as well, and so we encourage you all to take a look at that, and again to remember that this is going to be, now that we have the process worked out, we're going to be looking to push out more and more of the great research that you all are doing, in part through this podcast mechanism. It's a great feature. I thought the first version turned out very well. Paul Halverson, the Secretary of Health in Arkansas, is our host for these podcasts. And so, again, if you have ideas, you got findings that are ready to be disseminated and discussed with Halverson through the podcast mechanism, which we think is particularly going to be useful for reaching some of our practice colleagues, let us know. We're going to be doing more of these in production on a rolling basis. Upcoming meetings, obviously APHA is coming up. There's a slate of Academy Health webinars as well that you see here on this schedule. Look at the agenda that we sent out for this meeting earlier in the week that has actually, that agenda has electronic links that you want to register for any of these webinars. All these Academy Health webinars listed here are free. Most of them are tailored to PHSSR specifically. I can tell you that the November 14th webinar you see here, Rapid Cycle Evaluation, actually features several of our PBRN studies. I'm not going to tell you which ones yet. You're going to need to register. Those of you who are speaking as part of that know who you are. The rest of our family and colleagues in PBRNs, you're going to need to register for that webinar on November 14th to see the great work and the methods that are being used for rapid cycle evaluation in our PBRNs, profiled in that webinar, hosted by Marcia Gold at Mathematica, really an internationally known scholar in this technique of rapid cycle evaluation, along with David Dyack, who's a researcher and senior official at NACCHO. You do not want to miss that, as well as these other webinars. So I want to make sure everybody's aware of that. Okay, next slide, next item on our agenda. Now I will hand off to Lizette, who's going to take us through our administrative moment, our grants administration corner for this month.
Thank you, Glenn. Okay. I just want to take a few minutes to talk about the system for the electronic submission of reports and other grant products to the Robert Wood Johnson Foundation. As Glenn mentioned, it's really important to follow these guidelines and to submit all of the products related to your grants so that the foundation can stay current of your latest work. Many of you are already aware, obviously, of this, of some of these standards. For example, we know that that electronic versions of all of your reports, your bibliographies, and your products need to be submitted to RWJF at grant reports at RWJF, and of course a copy needs to be sent to us here at the center. The subject line of your email should have your 5-digit award ID followed by either report, bibliography, or product, depending on what it is that you're sending. Now, you can send multiple products as long as it has the same grant ID. So if you are sending a report and a product for the same grant ID number, you can include both of those in the same email. Just make sure you in the subject line that you do have those two things stated. Let's see, there's some limitations about size, and it can't be more than 10 megabytes. You can zip the file or do some other things. You can contact us here at the center. We can show you how to submit some of those larger files. And the file formats that you see here are, most of us are using PDFs. Even if we have PowerPoint presentations, we convert them to PDFs. Sometimes that's a lot easier. But as you can see, there are many other acceptable file formats. Okay. So these are the report naming standards. So now we're just talking about the reports. It's usually, your $5-digit grant ID number followed by the document type, the year, the period number, and the file extension. Now, for most of our grants, we don't have a period number, so you don't have to worry about that. But an example would be, as you see here on the right, let me get my little pointer. Okay. So you can see your 5-digit grant ID. ANR is an annual narrative report, followed by, this would be for year 1, and this happens to be a PDF. So the document types for the reports are annual narrative reports, final narrative reports, your bibliography, your annual financial report, and your final financial report. And we are all very aware of those. You already are doing that part pretty well. What I want to focus here is about product naming standards for your products. So there are 6 main types of products. There are articles, book chapters, communication, education, meetings, and reports, and we'll go over these briefly. Again, the naming standards need to be the 5-digit grant ID followed by GP for grant product, the type of document that it is. So that'll be one of these 6 types, followed by the number in that category. So if in the example here, you can see that they are submitting a meeting grant product, and this is the 4th meeting grant product that they are submitting. it's important to keep track of what number you're on. If at any time you're not sure, you don't remember what number you're in that category, please contact us and we can help you with that information. So now I want to focus on the 6 different types of products. These are all grant products. So let's take a closer look at those. So for articles, a lot of you are submitting articles. Obviously, it's one of the major products of some of our work. And these are journal articles or abstracts. This can also be magazine, newspaper, or newsletter articles on your results or findings or recommendations by a project or program staff member. So I know everybody thinks about journal articles and abstracts, but let's not forget the magazine, newspaper, newsletter articles. Those are considered grant products as well. Additionally, editorial, commentary, letters to the editor, these that provide facts or recommendations gained through your grant-funded activity. This is also a product. Special issues or supplements, and of course, manuscripts submitted for publication. And as you can see, the naming standards are as follows. If I can pick up my arrow. Anyway, it's the 5-digit grant ID number followed by grant product, GP, article, and the number in that sequence. I don't want to focus, let me go back a bit. I don't want to focus too much on what not to submit. There you can see the guidelines on what's not considered an article, and also special instructions. For some things, this is going to be more complicated. For articles, it's very easy. In the body of the email, you include the journal and the title of the journal and the year of publication. Okay, moving on to books or book chapters. So this is something that will have an ISBN or an LC number, or if it's a chapter, it's part of a publication that will have that number. And it includes manuscripts if they're not yet published. Again, the naming example is the 5-digit number, GP, book, chapter, CHPT actually, followed by the number. And the special instructions for these are, if it's a book, you do have to submit the hard copy of the book. I don't think that we have too many of those yet, but it's a possibility. All right. I do want to take a little bit of time to talk about communications and promotions, because I think this is one category that I believe you're doing a lot of work on, and we may not be capturing all of your results. So these are the types of things that you should submit under this communication category. They're media or press kits about your results, your findings, your recommendations or solutions of a project or program, press releases, video news releases, interviews, reviews of books where the author is staff, a program or project staff, project or program website URLs, and we had one of these recently, any uploads to video sites such as YouTube, any television and radio coverage, any blog entries, including the responses. That's all considered a grant product that will fall under this communication category. Of course, any photographs of activities supported by your project. For this, we do need to have a signed release from those pictured and copyright release to the Robert Wood Johnson Foundation. And if you contact us here at the center, we can provide you with those forms. Any advertisements, any awards, or any unique promotional items are also considered grant products. There are some guidelines on special instructions on how to submit some of these things, and I'll be happy to talk to you about those if you have any of these products. You can see the naming type is, again, 5-digit grant ID number, GP, and COMM for communication. Some of the things that you don't want to submit are print and internet coverage, things that are actually going to go on your annual narrative report. You would not report here as well. Announcements of grant contract awards or hiring of personnel, things like that. Okay, the fourth type of grant product that is education or toolkit. Again, these are materials created by the project or program used to instruct or deliver educational content. These can be guides, manuals, toolkits, and toolboxes, and we have had some toolkits, curricula and other class materials, educational, documentary, or retrospective TV, radio, electronic, any training or educational software, and evaluation tools or documents giving instruction or guidance about how to perform evaluations. These are considered education or toolkit grant products and do need to be submitted. Again, you can see the guidelines or contact us here at the center for specific guidelines for what you can send and what is not to be submitted. And the naming standard for this, again, is the 5-digit grant ID followed by grant product, education, and then the number in the sequence. The fifth type of grant product is meetings or conferences, and I think this is probably one of the most common grant products that we have. You can see their proceedings, transcripts, supporting materials from projects or program-sponsored meetings and workshops. I do want to let you know that if you are sponsoring a conference or workshop, anything that has to do with that is considered a grant product under this meeting or conference category. So your agenda, providing a list of speakers, the titles, the presentations, all of that needs to be submitted. Any proceedings of a sponsored meeting or workshop. If proceedings are unavailable, you can submit the presentation materials that were presented at the workshop. Any background papers that were prepared for discussion at the conference, those can be submitted as well. Any presentation or testimony materials containing research findings from the project or program and or results or recommendations from implementation of the project or program are considered meeting or conference grant products. And again, some of the examples of what not to submit are materials related to the logistics of the meetings, materials that report on activities that are peripheral to the results of the project or program. Those are probably some things that do not need to be submitted. If you have any questions about whether you think something falls under this category or not, please contact us and we can help you sort that out. The file naming example here is the 5-digit grant ID, GP, and then meeting, followed by the sequence. The last product is communications or promotions. And this might be something where some of you might have some results and that you're not sure if fall under this category or not. But these are media or press kits about the results, your findings, recommendations, or solutions of a project or a program. Any press releases. I'm sorry, I'm on the wrong one. This is my last one. These are reports. So reports or monographs, executive summaries of your report, synthesis, case studies, issue briefs or policy briefs, fact sheets, literature reviews, theses, charts and data reports, maps that include data, and newsletters that focus on your findings. I know many of you are producing newsletters. And of course, survey instruments. There's certainly plenty of that. So we need to have those things sent in as a report grant product. There are some specific instructions for data tapes and things like that. And again, contact us here at the center and we can guide you through that process. The naming example, as you see here, is the 5-digit grant ID followed by GP for grant product, report, and then the number in that sequence. And I believe that's all I have. Does anybody have any questions on this? Okay. If you have any questions, you can contact us here at the center. The foundation has recently made some changes to their website. They're extremely, extremely helpful. If you want to read a lot of this on your own, that's fine. I have a question here from Susan. Go ahead, Susan.
Yes, this is Susan Donner. I have a question about what the statute of limitations, if you will, is. The research funding from RWJ ended, say, for the network as a whole in November of 2011. We've continued, of course, to do things, but I haven't been sending those things, like a newsletter, in after the end of the funding. And I know we have some quick strikes who are past the end of their funding as well. So how how long do we keep doing this?
Well, the short answer is there's no real statute of limitations. I mean, obviously the foundation wants to, if these are products from work they funded, they want to hear about it. We want to hear about it if it's a product from your PBRN. And so, and I can tell you my strategy as the grantee is to always update as those new products happen. And so I think that's the best policy. And again, networks, you all are going to have individual research projects that that have funding that begins and ends. Many of our networks have multiple projects with different kinds of different timelines. But the short answer is if the product of that funding mechanism that the foundation provided to you, you should submit products even after that occur outside of the timeline of the award.
And we always keep a track of all of that. So again, if it's something that it's been a while and you don't remember exactly where you were in the sequence of that product, please contact us, and we'll be able to help you. That's a great question, though.
I know that we are at our time, and so we probably need to say goodbye for now in the interest of time. Again, thanks to everybody for your participation today. We again thank our colleagues at RAFI, Scott Frank and his colleagues for their great work and their presentation. Let us know, give us a call, send us an email if we can be of help, and we hope to see many of you next week at the APHA annual meeting. So long, everybody.
Bye.